am very, very happy to be participating, and I was very excited to learn about your group. This is such a cool group that you've put together.
Thank you so much.
So, and forgive me that I'm going to be speaking in English. My Spanish, as one discovered before this conference, still suffers from a lack of practice. But I wanted to talk a little bit about how to use ultrasound in the point of care setting to assess a patient in shock. And I don't have any financial interests into any of the products that I'll talk about today. I also try not to refer to any specific manufacturers when I speak. But I am biased in this subject because I believe that clinician-performed ultrasound can make physicians better at caring for their patients. The way I wanted to talk about this, I'll describe shock briefly because I know that you're all very aware of the mechanisms. And then I'll talk about the conventional ways that we assess a patient in shock. And then I'll talk about the ways that an ultrasound can offer an alternative method for assessing a patient in shock. I'll describe some of the ultrasound appearances of different shock states, and then bring it back to talk about some of the clinical applications for managing a patient in shock. And so first, when it comes to defining shock, we think about shock as a life-threatening state, one where the real concern is the lack of oxygen delivery to tissues. And we often think about that as something that we can fix by restoring perfusion. When we think about shock, though, we think about a complex system of lack of oxygenation due to many different causes, ranging from mitochondrial dysfunction through the more simple and straightforward problem of a lack of blood pressure to perfuse the cell. Shock states are commonly broken down into four. The distributive shock state that we see with sepsis, where the main problem is vasodilatation of all the capillary beds. A hypovolemic shock state, which we see when somebody has massive hemorrhage or dehydration. Cardiogenic shock, where the problem is ventricular failure preventing forward flow. And obstructive shock, such as tamponade or tension pneumothorax, where there is actually an obstruction to flow from the heart. From an epidemiological standpoint, most shock that is seen in the world is distributive because sepsis is such a large cause of pathology. But the other mechanisms for shock are present, and it's important to know which one we're dealing with if we're going to treat the patient appropriately. And that's where we get into our conventional methods for seeing what shock state we have. One of the most common ways, and to this day a valuable one, is to see whether the patient has cold extremities, with the idea being that these cold extremities represent a hypoperfused state. We also think about evaluating the neck veins of the patient, with jugular venous distension being consistent with a cardiogenic or obstructive shock state. We can auscultate, thinking about whether we're listening for pulmonary edema, but the sensitivity and specificity of physical exam for shock state has been shown to be very limited. Chest X-ray and other standard radiological techniques similarly have low sensitivity for differentiating shock state. There's if a patient has continuous measurement through the arterial catheter, you can measure pulse pressure variation, seeing how much the pulse pressure changes during the respiratory cycle. But this technique can only be used in a patient who is in sinus rhythm and who is not on low tidal volume ventilation. And so the number of patients that this is actually useful for becomes very limited. And then there was commonly the pulmonary arterial catheter, the Swan-Ganz catheter, was used for decades to differentiate different shock states. But in this cleverly titled review by Marek in 2013, he talks about the fact that any evidence to demonstrate a mortality benefit from PA catheter utilization has shown no benefit at all. There's also lab tests such as lactate, where determining that cells are in an anaerobic state can let you know that the patient has shock, but it doesn't necessarily differentiate the types of shock. This is where ultrasound can become really useful. When I think about the ultrasound windows into the body, I think about our ability to assess the central vessels, the inferior vena cava, the superior vena cava, the internal jugular and the carotid. I also think about basic echocardiogram, looking at the heart. I think about the lungs as a new and very exciting ultrasound window, and then we can talk about ultrasound of the abdomen and of the veins in the legs. So in order to assess the inferior vena cava, the ultrasound, usually a phased array or curvilinear trobe, but preferably one that can do a high frame rate, is placed in the subxiphoid region. You can see the hand positions being demonstrated on the screen. And you can see the anatomy that that will bring up for you. You can see the right atrium on the right-hand side of the ultrasound screen, the IVC moving across the screen in a longitudinal view, and the hepatic veins draining into the IVC. It's very important to identify this anatomy because that lets you know that you're in an appropriate plane of visualization and that you're not going to mistake the IVC for another vessel, most commonly the aorta. In a spontaneously breathing patient, the IVC has been proposed as a visual representation of the central venous pressure. And if you look at the American College of Emergency Physicians, this is actually still on their website, where if you look at the size of the IVC and how much it changes with the respiratory cycle, you can make an estimate of the central venous pressure. The problem is that when it actually comes to how this performs in trials where we have patient with invasive monitoring and an IVC assessment by ultrasound, it's not really satisfying with C-squared statistics of 0.5, 0.6, which means that it's not perfect by any means. It's also a bit confusing because if you think about a patient who's on mechanical or positive pressure ventilation, whether it's through intubation or through a BiPAP machine, you have to think about the IVC collapsibility completely differently. And during spontaneous inspiration, we decrease our intrathoracic pressure, which means that the abdominal IVC collapses in order to have blood flow towards the heart. When you're ventilated, or a ventilated patient on the other hand, during inspiration, there is positive intrathoracic pressure, forcing the IVC to dilate in the abdominal cavity. This actually is an interesting phenomena because instead of just thinking about this as a pressure phenomena, which would allow us to estimate central venous pressure, we can think about this as venous capacitance. How much more blood could the venous system tolerate before the IVC is maxed out at its maximum diameter? And as such, it actually performs a little bit better than invasive measurement of CVP to predict patients who are going to be volume responsive. In a meta-analysis that was done in 2010, I believe, you can see that there are a limited number of studies, but that the sensitivity and specificity provided for mechanically breathing patients was very high, giving us an odds ratio to predict whether IVC was capable of determining who would benefit from a volume bolus of 30.8, which is incredibly valuable clinically. Under a spontaneously breathing scenario, on the other hand, the confidence intervals got very close to 1, suggesting that we weren't sure that there was actually any benefit to it. A later meta-analysis that included more studies actually found worse performance, demonstrating that as we go and learn more about the IVC, we have to become more and more suspicious of the blind faith that some people put into IVC assessment. The superior vena cave, on the other hand, is a little bit less bothered by some of the confounders for the IVC, such as changes in intra-abdominal pressure, and instead is just looking at the way that intrathoracic pressure varies during the respiratory cycle and how that affects the superior vena cava. The real challenge with this, however, is that it's only known to be accessible through transesophageal echocardiography, which is not available in many settings, including my intensive care unit, but does allow you to access these views without worrying about body habitus or obesity. There are several studies demonstrating that an endocavitary probe can actually be used to assess the SVC in a thin patient, but that's pretty challenging to pull off in my experience. When we think about the ability of the SVC to predict who's going to respond to volume, who's going to improve their shock state based on their SVC dynamics, we can look at this large study that was done in France by Villén et al. I find this study to be really valuable. It was more than 300 patients, and they had performed a number of different evaluations on them, repeated those evaluations with 2 observers, and then gave them all a fluid bolus to see whether they responded. And you can see these different receiver operator curves for tests such as pulse pressure variability, change in SVC with respiratory cycle, and change in IVC diameter with respiratory cycle. And what you can see is that the SVC is better than the IVC, but if you look at the area under the receiving operator curve, that assessment that gives us in a single number how good a test is, with the perfect test being 1 and a terrible test being 0.5, we can see that the IVC and the SVC are not really all that great. Also, the IVC, as you've probably experienced, is difficult to assess in critically ill patients because they get abdominal distension for a number of different reasons. It is, however, the ICC being the intra-observer correlation, shows that actually it is possible to get this test done by several people and to trust that what one person sees, the other person will also see. The IJ is a traditionally used physical exam maneuver for assessing shock states, but sometimes, especially in America, thanks to our fast food industry, we can't see the IJ due to overlying tissue. With an ultrasound, on the other hand, you can assess the IJ even in a patient with a large beard or a patient with obesity, and you can see in the longitudinal view this paintbrush pattern, this descending walls of the IJ that collapse as the patient breathes. And this is what my IJ looks like as I breathe, letting you see the my jugular venous distension when I'm lying down flat. Those three findings were really just representations of the central venous pressure, and my interpretation of the evidence for central venous pressure to really guide shock resuscitation is that it's very limited. A more novel method is the carotid Doppler ultrasound. And there's a nice video of this available on the Massachusetts General Hospital's educational website in their emergency medicine department. This is more easily accessible than the aorta. Assessing the carotid is often very easy with an ultrasound. And by using spectral Doppler, you can quantify flow through the carotid artery. The idea is that the cerebral perfusion is going to be more consistent than any other artery in a shock state, so that we can trust the blood flow and changes in blood flow with an intervention. This particular study, intervention was studied by Marek, and what he showed was that in a very small study of 34 patients, when he did a passive leg raise and measured change in carotid blood flow, some patients had a dramatic response, 80% change in blood flow, while other patients had almost no response, 0.1% change in blood flow, and that this correlated very tightly with who was going to respond when he later gave them an actual fluid bolus. This was repeated by another group, however, who got much less impressive results. This was admittedly in cardiac surgery patients, but this was with a Swan-Ganz catheter in place as a gold standard measurement, and they showed that there was very disappointing performance. So that's how I think of the central vessels, with the IVC being the most commonly accessed, and that the IVC is really useful at extreme values, when it's flat or when it's completely dilated, but being very less trustable when it's in those middle zones, when it's more than 1.5 centimeters, but less than 2.5 centimeters, when it collapses a little bit, but not all the way. When it comes to the heart, however, we can get a little bit more information. The 2013 New England Journal review really used cardiac echo to differentiate the shock states, where distributed shock had preserved contractility, usually, except in the cases of septic cardiomyopathy. That hypovolemic shock had small or underfilled chambers. Cardiogenic shock had dilated chambers with poor contractility, and obstructive shock either had a visible pericardial effusion or a dilated right heart for a pulmonary embolism, or a visible pneumothorax. Visual assessment of the left ventricular ejection fraction can definitely help to evaluate for cardiogenic shock. I'll describe the way that we do that in a second. We can also look at the ratio of the left ventricle and the right ventricle in order to see how the RV compares to the LV from a pressure standpoint. And we can look a little bit at the way the RV is moving in order to get an idea of right ventricular function. The pericardium is easily visualized with ultrasound and can definitely be used to assess for obstructive shock. Differentiating distributed and hypovolemic shock are more difficult, and we'll talk about that in a second. So when you're looking at the parasternal long axis view, and again, this is with the hand held in the second to fourth intercostal space on the left side of the sternum, with the indicator on the probe pointing towards the patient's right shoulder, we can look at a couple of different things. One of the first things that we can look at is the LV diameter change in the way that the wall thickness changes. That's referred to as the unidimensional shortening or the fractional shortening. And if you look at the normal heart on the left, you can see that that LV cavity, I'm not sure if you can see my mouse, but the LV cavity being the deeper of the two ventricles, you can see that those walls come together about halfway. Anything more than 33%, anything more than a third in terms of the decrease in diameter of that cavity, corresponds to a normal ejection fraction. That's not perfect. It's a unidimensional measurement for a three-dimensional outcome, but it performs pretty well. If you look at the heart of a patient in cardiogenic shock on the right side of the screen, you can see that the LV walls are not getting closer together at all. This is a patient with an ejection fraction closer to 5 or 10%. You can also look at the anterior leaflet of the mitral valve. If you look, that anterior leaflet of the mitral valve in the normal heart gets really close to the septum, whereas in the heart with cardiogenic shock, it barely gets to the edge of the LV cavity, staying more than 2 centimeters away. When we come to assessing the ejection fraction, you can do this from each view of the heart. This is what it looks like from the parasternal short axis view. You can see that if you look at the red dot in the center of these two videos, that the walls come in. And again, in this parasternal short axis view, that's where I like to use that fractional shortening, a change of a third, reflecting that there is a normal ejection fraction. This is also a view where you get to see regional wall motion abnormalities, which are a problem if you're assessing a patient who may have been having acute coronary syndrome. When it comes to assessing the ejection fraction, there's some fairly good evidence that this can be learned. With just 2 hours of study, a group in 2009 was able to demonstrate a sensitivity and a specificity of internal medicine physicians for detecting abnormal ejection fraction of 80 and 92%. With 12 studies, that increased to above 90%. With 27 hours, it was in that high 80% range. And then with the kind of gold standard of 3 months and 100 studies, you're again above 90% in sensitivity and specificity. The way I internalize this is to say that there is some number of studies that's essential for each person, and that number will be different. Many guidelines now recommend that for point of care ultrasound, the number is somewhere around 25 supervised echocardiograms in order to feel confident that the information that you are taking from the study is the same information that a cardiologist would take from the study. But it's also important to remember that even cases with normal ejection fraction can have cardiogenic shock. This is an example of a patient with very thick walls who has preserved ejection fraction, but clearly is not pumping out a lot of blood. Ultrasound can give you this information as well, but at the moment it hasn't been as well studied how to use this from a performance standpoint. The other parts of the cardiac evaluation are measurements of the cavities. In this part, you can see a dilated left ventricle, a dilated left atrium, and these things can be seen in hearts that have cardiogenic shock, as opposed to very small ventricles, or very small atria, which would suggest underfilled hearts. But again, these measurements have only demonstrated performance when you're dealing with a heart that does not have diastolic dysfunction. And at least in our intensive care unit, many patients do. When it comes time to assess the right ventricle, which can be indicative of obstructive shock due to pulmonary embolus, there's information that can be gathered from each of the views. In the parasternal long view, you can see a large right ventricle. When I say large, what I mean is that the right ventricular diameter should be about the same as the aortic outflow tract or the left atrium. If one of those is bigger than a third, then something's wrong. In the parasternal short axis view, you can see the left ventricle being forced into a D shape. This is because the diastolic pressure in the right ventricle is higher than the diastolic pressure in the left ventricle, forcing the septum paradoxically towards the left ventricle. In the apical 4 view, you can compare the size of the right ventricle to the left ventricle directly, remembering that a normal right ventricle is around 60% of the left ventricle diameter, but that anything between 0.6 and 1 is considered normal. In this view, you can also look at the tricuspid annulus, and this is the measurement that's referred to as TAPSE. You can see that the tricuspid valve, which is on the left side of the heart, because it's the right ventricle is on the left side of these ultrasound screens, that tricuspid annulus moves up and down on the screen. And the normal heart on the left, the tricuspid annulus moves briskly, and it moves more than 1.5 centimeters. Whereas in the heart on the right with right heart failure, you can see that the tricuspid annulus barely moves at all. Several societies have gotten together and said that it is reasonable for us to be doing basic echocardiogram. The American Society of Echocardiographers, an international consensus, which includes the European, several European groups. And what they've said is that it's reasonable for a bedside examiner to look for LV abnormalities, specifically a couple of the ones we talked about: qualitative systolic function, LV hypertrophy, LV enlargement, similarly the left atrial enlargement, several right ventricular abnormalities, including a big right ventricle, or no, right ventricle that's not moving. They talk about pericardial effusions, which I want to highlight just because that's one of the ones where the evidence is strongest for a point of care practitioner for us to assess for a cause of shock. They also talk about the IVC and these kind of non-specific descriptions of gross valvular abnormalities or large intracardiac masses. When it comes to pericardial tamponade, the most sensitive finding is actually a large unchanging inferior vena cava. But this is obviously very non-specific because there are many different reasons for people to have a large IVC. The subxiphoid window is my preferred window for evaluating for pericardial effusion. And as pericardial pressure increases, first, the inferior vena cava becomes unchanging. If you think about it, that makes sense. In order to have an unchanging IVC, you have an elevated right atrial pressure, which is a sign that you're getting towards the equalization of pressures, the hallmark of tamponade. Then the right atrial begins to collapse. You can actually see in this video right atrial collapse during systole, as opposed to what you'd expect. And then you can see RV collapse when the pericardial pressure is greater than the RV diastolic pressure. The problem with this is that sensitivity and specificity range wildly in different studies of when RA and RV diastolic collapse are reliable in order to determine that somebody's in pericardial tamponade. Also, a nice trick is that the parasternal long axis view lets you differentiate a pericardial effusion, which goes between the descending aorta and the heart, from a pleural effusion, which goes behind the descending aorta. Otherwise, on ultrasound, it can be very confusing whether you're seeing a large pleural effusion, as in the case of the parasternal long axis view on the left-hand side of the screen, versus a pericardial effusion. I also want to touch on some advanced ultrasonic techniques, specifically Doppler. By using spectral Doppler, you can measure the blood flow moving through the aortic valve. This is typically done in the apical 5-chamber view. And if you gate your pulse wave Doppler at the aortic valve, adjust it slightly for angle, and you measure the biggest peak and smallest peak during the respiratory cycle, you can see how much variability there is in cardiac outflow through the aortic valve during the respiratory cycle, in the same way that you're kind of assessing how the IVC changes based on the change in intrathoracic pressure during the respiratory cycle. But it turns out that the performance of this, while better than pulse pressure variability, is not amazing. On the other hand, you can calculate the actual cardiac output by thinking about the stroke volume and heart rate. If you think about the things that go into the stroke volume and heart rate, it's a measurement of the left ventricular outflow diameter, a correction to get from diameter to area, and then the volume time integral, that spectral Doppler measurement of cardiac outflow, of blood flow through the valve. When you multiply that by the heart rate, you get the cardiac output. That's a useful finding that's been validated against Langerhans catheters in several studies, but is definitely more challenging for the beginning practitioner. Something to look forward to as we become more advanced in this. Lung ultrasound is one of the things I'm most fascinated by because previously textbooks would state that ultrasound of the lungs was a useless endeavor because of the air scattering the sound waves. Lichtenstein in 2008 really proposed an algorithmic method to use just lung ultrasound to determine the shock state of a patient. And this was only for patients in respiratory failure, but if you think about what you're seeing here, it's actually fairly sensible. At the same time, my first thought when I saw this algorithm was that this was way too complicated. But I'll walk you through it, and it really only involves two questions. The first question is there lung sliding when you do your lung ultrasound? And this is a lung ultrasound of a patient I evaluated. And determining lung sliding involves looking
in the area highlighted in the red box and seeing if there's a shimmering, or if you're a computer nerd, if each of the white pixels alternates between white-black or white-black. That's the sign that's generated by two layers of pleura, the visceral and parietal pleura, moving against each other during the respiratory cycle. In contrast, this is a patient with a pneumothorax where those two layers of pleura are not against each other. And you can see that that white line no longer shimmers. Instead, it just appears to move back and forth. If lung sliding is present, for example, in this patient that I was evaluating, then you have to determine whether the patient has a B profile or an A profile. Now, Lichtenstein described two patterns. He described A lines and B lines. And you can see that A lines are these horizontal lines that are reflections of the pleura. They're an artifact generated by sound waves bouncing back and forth between the transducer, the pleura, back to the transducer, and sometimes back to the pleura and back to the transducer, making the ultrasound machine think that there is a second and third pleural line 2 and 3 reflections deep. B lines, on the other hand, are when sound waves are trapped within the alveoli and generate these vertical lines that move back and forth with respiration, obliterate A lines, and go all the way to the bottom of the screen. Lichtenstein basically said that based on whether there was lung sliding and whether or not it was an A or a B profile, he could determine the cause of somebody's respiratory failure. And in the case of a patient who has lung sliding and a B profile, that meant that they had pulmonary edema. You can see how an absence of lung sliding plus lung point would give you a pneumothorax, and how multiple different profiles can lead you to a diagnosis of pneumonia. He described some amazing diagnostic performance that hasn't quite been replicated, but there was an international consensus statement put together on lung ultrasound in 2012. And that consensus statement, instead of using the 3 points described by Lichtenstein, they suggested 4 zones on the anterior chest, or if possible, 2 zones on the posterior chest. This is a review that I put together for the Journal of Thoracic Disease. And what you can see is that for multiple different disorders, there's been meta-analyses showing very impressive performance of lung ultrasound for the diagnosis. Everything from pneumothorax, the presence or absence of pleural effusion, which are commonly used techniques, to diagnosing pneumonia, which previously was just used in the pediatric literature, but for which there's been 2 meta-analyses in chest and in intensive care medicine, just in the past 2 years. Diagnosing asthma is a bit of a diagnosis of exclusion, which is why we just trust Lichtenstein's study. But pulmonary edema has many studies showing incredible sensitivity and specificity. ARDS is a little bit more challenging, but being able to determine that can be useful in a patient who's on ventilation. And the future state, work being done now, is in determining the performance of ultrasound for looking at interstitial lung disease. Just as an example, the meta-analysis in 2011 demonstrated that ultrasound was much better at detecting pneumothorax than chest X-ray. This is in trauma patients. It's still a really useful technique. Lichtenstein also tried to use this to determine the shock state using what he calls his Falls protocol. He described this first in 2012, but the basic idea being he first did simple emergency cardiac ultrasound to determine whether there was tamponade, presence or absence of pleural effusion, whether there was a pulmonary embolism, presence or absence of RV dilation. He then checked to see if there was lung sliding, to see if there was a pneumothorax. If either of those states were present, it was obstructive shock. He used that, he managed that clinically. If there was a B profile when the patient first came in with acute circulatory failure, he assumed cardiogenic shock. Then, if they had an A profile, those horizontal lines, he started giving them fluid. His basic protocol was that he gives them fluid until they either get better or until they start having B lines on their lung ultrasound. This is akin to resuscitating someone with intravenous fluid until they become more hypoxemic. You can tell that this isn't exactly an elegant path, but it seems to have some clinical justification. There have not, however, been any studies talking about the clinical outcomes using the Falls protocol. Abdominal ultrasound has a great deal of evidence behind it. The FAST exam has been in use in emergency medicine for more than a decade now. And the FAST exam involves assessing the patient through 4 windows in the abdomen and assessing 10 spaces. In the right upper quadrant, you can see the pleural space looking for hemothorax, the subphrenic space looking for intra-abdominal hemorrhage. The hepatorenal recess has a very sensitive space for the free fluid in the abdomen, and the inferior pole of the kidney, because that's a place where fluid sometimes likes to hide. Similarly, the left upper quadrant lets you evaluate the same spaces except with the spleen. The subxiphoid view, as we already discussed, lets you see a pericardial effusion, pericardial blood, and the pelvic ultrasound lets you see if blood's hiding in the retrovesicular or retrouterine pouch. In a FAST exam, really what you're looking for is for those spaces, and this is a picture of the right upper quadrant. You're looking to see if whether there's any free fluid in the abdomen. You can see that the Morrison's pouch in the image on the left of a normal patient separates with anechoic fluid in the patient who has free fluid on the right. The sensitivity and specificity of this is incredible. In a meta-analysis, if you look at any patient who's hypotensive, this predicted whether or not they were going to need surgery, or if they had intra-abdominal fluid, with 100% sensitivity, 100% negative predictive value. If you look at all blunt trauma patients, not just the ones who are hypotensive, it still is incredibly specific, if not quite as sensitive. And we already talked about the fact that a pneumothorax is easy to assess, or at least reliably assessed with ultrasound. The last of the ultrasound windows is through the veins in the leg. And this is an assessment of the femoral and popliteal spaces. And when we talk about assessing these spaces, we're talking about doing compression-only ultrasound. And that means just applying pressure and seeing whether the vein completely flattens out. You can see the normal veins on the left where they completely collapse, leaving the artery deforming. And you can see on the right a vein that, in spite of pressure, stays open. That's the positive and negative finding in compression-only ultrasound. It was first described in the emergency medicine literature as being incredibly valuable. In a meta-analysis of 1,000 patients, just 2-point compression ultrasound was able to predict who had a DVT and who didn't. When this was attempted in the intensive care unit, however, the sensitivity was much lower. And the reason it turns out is that in the intensive care unit, people develop thrombi at the junction of the superficial and deep femoral veins. And that's not assessed in 2-point compression ultrasound. So Pierre Corey added a 3rd point and was able to regain some of the performance that was previously described. So now we've gotten a bit of an idea about how to look into the body using ultrasound. And now we can get into some of the appearances of different shock states. So for instance, this is a patient with hypovolemic shock. You can see a completely flat IVC in the bottom right-hand corner of the screen. You can see an intact ejection fraction based on the fractional shortening and based on the E-point septal separation. And you can see that the patient has A lines with lung sliding present in the lung ultrasound. We can compare this to a patient in a different clinical scenario. For example, I'm sorry, my computer's slowing down a little bit, but for a patient in cardiogenic shock, where in the parasternal short axis view, you can see that the walls are not coming together that necessary 33%. You can see that the inferior vena cava is dilated more than 2.5 centimeters and does not change with respiration. And you can see that on lung ultrasound, there are the B lines, these vertical artifacts that go all the way to the bottom of the screen. So if you see this pattern, it's most consistent with cardiogenic shock. Obstructive shock can have several different patterns. We've already talked about and seen what a heart with cardiac tamponade can look like. And let's give the computer a second. In obstructive shock, typically you see there it is, a dilated IVC. In pneumothorax, you see that pleural line that doesn't demonstrate the shimmering artifact of lung sliding. And in this video in the center, you can see visible thrombi in the right atrium. That's a clot in transit for a patient who has a massive pulmonary embolus. Even without that, however, which is not necessary to make the diagnosis, you can see that the right ventricle is very enlarged compared to the left ventricle. In septic or distributive shock, you get a picture that looks very similar to the one that you saw in hypovolemic shock, with an intact ejection fraction in your parasternal short axis view, a flat IVC, and early sepsis. But you can use lung ultrasound to frequently make the diagnosis of pneumonia, and that's what you're seeing here is consolidated lung on the left-hand side of that lung ultrasound screen, in that it looks like liver with a thin pleural effusion, a paramnemonic effusion in this case. This also demonstrates dynamic air bronchograms, a specific finding in pneumonia. All right, so now let's talk about how to use ultrasound once you know why your patient's in shock. The Surviving Sepsis Campaign's most recent iteration recommends dynamic variables to predict fluid responsiveness. It doesn't actually give any recommendation about what those dynamic variables are. We can't actually answer the question of how are we going to improve tissue oxygenation, but we can answer the question of, is preload going to improve cardiac output, or is it only going to increase extravascular lung water? And that's what we try to do with an ultrasound. There are a number of protocols that have been designed to try to answer this question. The RUSH protocol is the one that's most commonly used in our emergency departments and ICUs. But you can see that all of these different protocols use many overlapping assessments, different views of the heart, the view of the inferior vena cava, views of the lung, views of the abdomen, all the things that we've already talked about. For instance, the RUSH, which you can remember by thinking about the pump or an assessment of the heart, the pipes or an assessment of the inferior vena cava, aorta, and veins of the leg, and the tank for an assessment for pneumothorax, hemothorax, and intra-abdominal bleeding, is an examination that goes through all of these different views. It starts with a parasternal long axis view, then quickly goes to an apical four-chamber view to assess for signs of pulmonary embolus. It assesses the IVC for signs of collapsibility or volume overload. It assesses Morrison's pouch for signs of free fluid in the abdomen. It does an assessment of the abdominal aorta, looking for abdominal aortic aneurysm as a cause of shock. An assessment of lung sliding for pneumothorax. An assessment for ectopic pregnancy, which is not actually a part of my practice in the intensive care unit very frequently. An assessment for a DVT. And you can see here a positive compression ultrasound. We already talked about the individual components of the RUSH protocol and how there's some limitation to their diagnostic performance. But the evidence for this protocol really is helping go from undifferentiated shock to differentiated shock. And that's what they did in the study in 2015, where they looked and saw how confident people were in their differential before and after, and whether their management changed. What they found was that there was a 27% decrease in their diagnostic uncertainty after a RUSH exam, and it resulted in a change in treatment for about 25% of cases. They give several nice examples of places where their evaluation changed. For instance, in a patient where before the ultrasound they thought that they had septic shock, but afterwards they were able to see that they had bilateral pulmonary emboli with RV strain. A patient who they thought had a pulmonary embolism or a ruptured ectopic, who actually had a ruptured splenic artery aneurysm. A patient where they thought they had sepsis from a urinary source, but actually had an abdominal aortic aneurysm and impaired cardiac function. The list goes on, and you can see how this would be helpful. They also, there's been proposed in addition to their RUSH exam, which goes from just how to determine what sort of shock they're into, is what I'm doing helping the shock, and that uses that volume time integral, the spectral Doppler that we talked about, with the equation we talked about for the area of the aortic outflow tract, in order to determine what their hemodynamic instability is, and then what your goal is to perform interventions in order to increase your LVOT VTI. That study was from 2015 and is a valuable way to think about using spectral Doppler in order to help the undifferentiated shock patient. So just to wrap things up, we talked a lot about the different forms of shock and how ultrasound can help differentiate one form of shock from another. We talked about the performance of our normal physical exam maneuvers in order to determine shock states. And we talked about how ultrasound provides new windows into the body, letting us evaluate the patient with shock in ways that we previously couldn't do. And then we gave some examples of what those shock states look like when evaluating with lung, cardiac, and inferior vena cava ultrasound. And then we talked a little bit about a couple of protocols, the RUSH protocol and the FALLS protocol, as ways to help guide management once somebody has been determined to be in shock. There's a lot of things that are coming down the pipeline, things that are very exciting. For instance, Doppler measurement of renal perfusion as a way to determine whether you're adequately perfusing the kidneys. A better understanding of the performance of lung ultrasound. Some studies of the FALLS protocol are ongoing. Several companies have developed machines that automate the cardiac output calculations to make it easier for a novice practitioner in order to assess cardiac output using spectral Doppler. Several intensive care units in my hospital are using a indwelling transesophageal echocardiogram device where you actually get to leave the device in the patient for 48 hours and get continuous measurements of cardiac output, continuous evaluations of the heart. And then in our emergency department, we started using transesophageal echocardiogram during cardiac arrest in order to determine everything from, are the compressor's hands in the right place during CPR, or whether there's an answer for why the patient had a cardiac arrest to begin with. And there's some very interesting results coming out from that, especially in the last 2 years. The REASON trial is the name of one of the studies. So just to conclude, this is becoming the present of critical care in many parts of the world. Integration of different windows into your standard clinical examination really augments your ability to diagnose and to treat shock states. There are many ultrasound indicators that allow you to predict a volume response, and now you know how to do some of them and some of the evidence around them. But when it comes to real outcomes, mortality, measurements of tissue oxygenation, none of these have yet been measured in a clinical trial. So again, I apologize for the technical difficulties that we had on my side, and here's some cute pictures of my kids just to finish up the talk.
Thank you, Cameron. Thank you so much. It was a very, very nice presentation. Thank you so much. It was very, very illustrative. We have seen a lot of pictures, a lot of clips, and it was very demonstrative. Thank you so much, Cameron. I'm going to speak in Spanish. Do you prefer to hear, to do the comments and the questions in Spanish, and maybe you can answer in English as you prefer, okay?
Perfecto, perfecto, gracias.
Excelente. Bueno, muchas gracias. No sé si en la audiencia tuviéramos alguna pregunta, algún comentario. El doctor Cameron también entiende español y puede hablarnos también en español, nada más que para él, desde luego, fue más cómodo toda su presentación en inglés por obvias razones, pero él entiende muy bien español y podemos hacer los comentarios que ustedes deseen. No sé si en nuestros participantes alguien desee hacer algún comentario, solamente tiene que activar la función levantar la mano y les doy audio. No sé, por ahí Arnulfo, Iris, quisieran hacer algún comentario. Delphi, la doctora Juliana Ordóñez, Francisco Llera, Luis Ponce, Paula Gutiérrez, todos los que nos están escuchando, si gustan, pueden hacer algún comentario. Permítanme, el doctor, me parece que es Arnulfo. Adelante, Arnulfo, ya puedes hablar. Gracias por estar aquí.
Buenas tardes, muchas gracias al doctor Cameron. Excelente presentación y felicidades por su español. Y en nuestro centro utilizamos de rutina en evaluaciones, valoración por respuesta a volumen, diferentes parámetros desde la línea arterial, y ecocardiográficamente podemos utilizar varios. ¿Qué opina usted de, me llamó la atención la reproducibilidad de hacerlo fuera del tórax, ¿no? Mostraba un dato de vena cava superior de carótida interna. ¿Qué opina de la evaluación de la carótida interna, de la variabilidad que podemos encontrar en carótida interna y su utilidad cuando estamos haciendo reanimación en pacientes con dependencia de volumen?
Sí, entonces,
did you understand the question, Cameron, or you prefer I can translate as well?
Why don't you translate just to make sure?
Okay, very good. Well, Dr. Arnulfo from Guadalajara is questioning about the carotid, the use of carotid flow in order to predict volume responsiveness. I have to tell you, Cameron, that The group from Guadalajara, which is head of the Dr. Arnulfo, they are published some articles about the volume responsiveness by using the carotid flow. So for them, it's very, very interesting this question and to say something about the carotid flow, because they have published some articles about this. What is your opinion about the volume responsiveness by using the carotid flow, Cameron?
Sí. Entonces, inicialmente estaba muy emocionada sobre este tópico, porque parece que debe funcionar, ¿no? El carótido debe estar más o menos lo mismo durante... Actualmente voy a contestar en inglés, lo siento. At first I was very excited about carotid Doppler. The problem is that in addition to carotid flow changing during passive leg raise or during the respiratory cycle, the diameter of the carotid changes as well. And this is what was demonstrated by the group who did the study on cardiac surgery patients. Because the area of the carotid changes, and because the blood flow is dependent on the radius squared, they found that there was a large amount of inter-observer variability and intra-observer variability. So that, to me, makes this a little harder to recommend as a first-line method for assessing volume responsiveness. At the same time, if you have somebody who's very experienced with this and who is able to get reliable measurements, this is as good, if not better, than measurements of aortic outflow, because it's so much easier to access the carotid with an ultrasound as opposed to getting a view of the aorta.
Right. Perfect. Yes. Actually, I have no experience by using carotid flow. Also, I prefer to use the 5-chamber view. I learned by using apical 5-chamber view. So, well, there is another question from the audience, Cameron. La doctora Iris, que también es parte del grupo de la Asociación Mexicana de Ultrasonografía Crítica y Urgencias, nos comenta que cuál es tu método preferido o qué método utilizas para evaluar la respuesta a volumen en pacientes que tienen asincronías respiratorias. Me imagino que esto también incluye los pacientes que tienen respiración espontánea, dado que pues, son pacientes que no están con un volumen tidal uniforme. Cameron, in your opinion, what is the best method to evaluate the volume responsiveness or to predict volume responsiveness in patients with respiratory asynchrony or dysynchrony? Mm-hmm.
Yeah, this is important because all of the methods that have been described using the changes in the inferior vena cava with respiratory variation, or the changes in cardiac output with respiratory variation, go by the wayside if you have a patient who's asynchronous on the ventilator. Just as an example, the study that I talked about from France, where they did all of the different methods on the same patient over and over again, every patient in that study was paralyzed in order to be synchronous with the ventilator. That was in order to make sure the tests were as perfect as possible. But when we think about a patient who's asynchronous on the ventilator, we need to figure out another way to give them a small bolus of fluid without actually giving them a bolus. So my favorite in this is a passive leg raise. We have practiced with our nursing staff to lift the patient from an incline like this to an incline like this, and to assess the same thing, assess the inferior vena cava, assess the cardiac output, assess the carotid if that's your preference, with the passive leg raise in order to predict who will respond to volume. And when you're doing that, it shouldn't matter whether they're asynchronous with the ventilator.
Yes, of course. I think it's very, very important this. De hecho, el levantamiento pasivo de piernas, Cameron, si tú estás de acuerdo, creo que tiene muchísimas ventajas, sobre todo que puede ser utilizado el levantamiento pasivo de piernas y la evaluación del gasto cardíaco, pues de una forma invasiva o no invasiva, dependiendo de las tecnologías que tengamos, y sobre todo esto, que permite ser evaluado en respiración espontánea, con volumen tidal que no es uniforme, en pacientes con arritmias, etcétera. Por algo es el método, digamos, que es hasta cierto punto el mejor para estos escenarios. Bueno, hay otra pregunta, Cameron. El doctor Luis Ponce pregunta, ¿cuál es la correlación entre obtener el gasto cardíaco por medio del método de Fick y la ecocardiografía? ¿Hay mucha diferencia en los resultados? Cameron, I don't know if you can understand this question. The Dr. Luis is questioning about the correlation. If we can find a correlation or direct relationship between cardiac output evaluated by the Fick method, I mean by gases and so on, and the echocardiography. Is there a correlation in between?
Yeah, actually, I'm going to bring up a slide that I have available just to talk about that in 1 second. Here we go. Is that slide available now?
Yes, we can see perfectly.
Okay, so this is these are 2 studies that were done just in the last 2 years, looking at cardiac output measured by transthoracic echocardiography, and cardiac output is measured by Fick method. And the one on the left makes it look really good. You can see that all the line seems to be almost exactly 45 degrees, and the dots are all very close to that line. If you look at the slide on the right, this is the measurement of agreement. You can see that actually the variability can be pretty significant, by as much as 2 liters in several cases, which is concerning. So the way that I think about this has to do with, instead of thinking about it as a single measurement, which is very different depending on angular error, if you're not getting a perfect angle of the apical 5-chamber view, whether you don't have a perfect measurement of the left ventricular outflow tract, if you have an error tracing your volume time integral, I think about it as relative change. So instead of taking just the cardiac output from one measurement, I make sure to compare it after an intervention. And then I feel confident that the direction and magnitude of change as measured by echocardiogram, by transthoracic echo, is going to be the same direction and the same magnitude as that measured by Fick. And that's supported by the study in 2017 with very high test performances.
Oh, very, very nice. Thank you so much, Cameron. No sé si alguien más quisiera hacer alguna pregunta o tener algún comentario. Doctores, si quisieran hacer algún otro comentario, este es el momento, se los agradecemos mucho. Y bueno, parece ser que, la doctora Delphi está preguntando, haciendo un comentario. Dice, en nuestro hospital manejamos muchas pacientes embarazadas, y por la obesidad y la fisiología misma del embarazo con difícil ventana y que están en choque, ¿qué recomendaciones nos harías en estos casos, Cameron, in pregnant patients?
Yeah.
What are your recommendations for a correct evaluation and assessment in this kind of patients?
Yeah, and pregnant patients, it's more challenging to assess them for a number of reasons. They have different flow states. They have compression of the inferior vena cava. So it certainly is more of a challenge. One of the things that some people will recommend is the transesophageal echocardiography. And this is not available everywhere, and I know that, but it fixes the problem of obesity. And so in some of our intensive care units, we've started to move towards that for a truly obese patient. We have patients with body mass indexes that are greater than 60, where it's impossible to get a transthoracic echocardiogram. That being said, if transesophageal echocardiography is not available, then you have to use the windows that are. For those patients, the windows that are almost always still available are the lung and the carotid and internal jugular veins. So even though the internal jugular vein is very difficult to assess for a patient who's very obese with physical exam, with ultrasound, it is still easy. Similarly, the lung is oftentimes very difficult to assess through auscultation for an obese patient, but lung ultrasound will still let you see whether there are A lines or B lines. This still is limited as compared to your thin or non-pregnant patients, but sometimes can give you just a little bit of information to help you out.
Thank you so much, Cameron. Can you hear me right now?
Yes.
Yeah,
yes.
perfect. Okay, well, Cameron, regarding the V lines in cardiogenic shock, do you think that in patients with cardiogenic shock, we always will see V lines in this kind of patients? Is it mandatory to see V lines in patients with cardiogenic shock? If we see, for instance, if we have a patient with hypotension and hypoperfusion, and the cardiac output is low and the ejection fraction is low, and we see a very decreased mobility, etc. But if the patient doesn't have B lines, we must think in another kind of shock, or what's your opinion about this, Cameron?
Yeah, this is a very good question. We all know that no one has one form of shock. Everyone has overlapping forms, a little bit of cardiogenic, a little bit of distributive. And so for a patient who you see impaired cardiac function, but you still see A lines, the only way that's consistent is if they are also hypovolemic. Because as soon as they have enough volume, some of it will back up into the lungs. And I say that with the understanding that no test is 100% perfect. But at least in my experience and in the literature, the presence of A lines really strongly argues against a truly cardiogenic cause for the patient, unless the patient is also under-resuscitated. We know that our patients with impaired ejection fraction often do not get enough fluid when they have septic shock, when they have some other form of shock. But a resuscitated patient who has A lines, it's hard for me to believe that they have cardiogenic shock.
Yes, it's true. Cameron, actually, we can see in some patients, speaking about the overlap of shock in some patients, we can see a very low ejection fraction, but maybe this is a chronic situation, and the patient will respond to volume,
exactly.
even though the patient has a very low ejection fraction, but this is because this is a chronic condition, and the patient is undergoing a hypovolemic shock, isn't it?
Exactly. Hypovolemic or distributive shock with impaired ejection fraction is really common, and unfortunately is often mistreated because we are afraid to give fluid to somebody with an impaired ejection fraction.
Yes, and we can see we can see patients with a collapsed IVC with very low ejection fraction, or we can see patients with a huge inferior cava vein, but it's a chronic dilated IVC, and the patient still responds to volume, etc. Well, there are some questions, Cameron, if you allow me. One person is questioning about the Doppler. Yes, and the Doppler, the renal Doppler, what is your opinion about using the renal Doppler in patients with shock?
I'm excited about it, but I think the evidence is not there yet. I've only seen one study using renal Doppler, and it was just to predict whether a patient was going to respond from a creatinine measurement standpoint. So I don't think we're at a place where we can use renal Doppler alone to evaluate patients in shock. But I'm excited to see, as new studies come out, whether that changes.
Yes, very good. So we have to still integrating many other parameters and images, right?
Exactly.
Okay, very, very interesting. And as you can see, this is a very interesting topic. This is a very hot topic. There are a lot of people interested because many of us started by using ultrasound just in this specific setting. And well, apparently there are no more questions, Cameron. I really appreciate your attention. Thank you so much for being part of this webinar. I really appreciate it. Do you want to say something to the Mexican and Latin American audience, because right now there are people from other parts of Latin America, Colombia, Ecuador, Bolivia, Argentina, etc. Many people is in other part of Latin America. Thank you so much. Do you want to say something to our audience, Cameron?
Sí, sí. Entonces, muchísimas gracias por la invitación. Estoy increíblemente impresionado por la manera en que ustedes están usando esta tecnología nueva. Es muy impresivo. Espero que esta información pueda ayudar un poco con las próximas examinaciones que hacen, pero yo sé que ustedes van a cuidar por sus pacientes en una manera perfecta, sin o con ultrasound. Entonces, gracias y gracias de permíteme hablar con ustedes.
Gracias, Cameron. Nosotros estamos sumamente agradecidos porque, pues bueno, verdaderamente es una presentación sumamente completa, muy completa, tal como tu artículo publicado es exactamente así de completa, así de fantástica. Te agradezco mucho que hayas tocado los mismos puntos que en tu artículo y realmente nos tiene eso muy emocionados, Cameron. De verdad te felicitamos por el artículo que publicaste en esta revista y nos ha servido muchísimo porque hiciste una revisión de la medicina basada en evidencia, de los principales protocolos, lo cual a nosotros nos encanta verlo de esa manera. Muchas gracias, Cameron. Thank you so much. I'm gonna finish the webinar. Thank you so much. I appreciate all your attention, your willingness. Thank you for being part of this webinar once again.
Muchísimas gracias.
Gracias a ti. Nos estaremos saludando pronto. Muchas gracias.
Muchas gracias.
Adiós, bye.
Adiós.